Hello, my name is Michael Bartel, and I'm a gastroenterologist and therapeutic endoscopist at the Fox Chase Cancer Center in Philadelphia. Today, I would like to present our study titled The Role of EUS in Patients with Suspected Barrett Esophagus with High-Grade Dysplasia or Early Esophageal Adenocarcinoma that will be published in the upcoming GIE edition. First of all, I would like to introduce the senior author, Dr. Michael Bartel from the Mayo Clinic in Jacksonville, Florida, from where the study originated from. The motivation for the study was based on the published ACG guidelines in 2016 on the diagnosis and management of Barrett's esophagus. The guidelines stated that routine staging of patients with nodular Barrett's esophagus with endoscopic ultrasound or other imaging modalities before EMR did not demonstrate any benefit. The caveat is that initial studies addressing EUS and esophageal cancer from Japan showed high sensitivity and specificity for T1A and T1B staging. However, the more recent studies from Europe and the US showed conflicting reports, with sensitivities ranging from 39 to 100% for T1A and T1B staging. The significant challenge interpreting those studies is that most originated from surgical cohorts, which do not reflect the usual gastroenterology patient population, which consists of mainly non-dysplastic and dysplastic Barrett's esophagus. Therefore, we were interested to measure in our gastroenterology patient population how well EUS can differentiate between patients who will require surgical resection, which is based on a cancer invasion depth of T1B or deeper, from patients whose dysplastic Barrett's esophagus and early esophageal cancer can be treated endoscopically, defined by a maximal invasion depth of T1A. We did a retrospective study and included all patients who underwent esophageal EUS at the Mayo Clinic in Jacksonville, Florida, between January 2006 and June 2014 for premalignant Barrett's esophagus and suspected early esophageal adenocarcinoma. A total of 335 patients, mostly male patients, who underwent esophageal EUS were included. The PROC-C mean length was 2.7 cm and PROC-M mean length 4.5 cm. Nodular Barrett's esophagus, which corresponds with Paris 2A lesions, was detected in 64% of patients. Based on endoscopic biopsies or mucosal resection, 42% of patients had high-grade dysplasia, 24% low-grade dysplasia, and 12% non-dysplastic Barrett's esophagus or no Barrett's esophagus. 22% of patients had invasive adenocarcinoma, with 47 patients T1A, 25 patients T1B, and 3 patients had T2 adenocarcinoma. In terms of correct selection of patients to undergo endoscopic or surgical resection, EUS had a sensitivity of 50%, specificity of 93%, positive predictive value 40%, negative predictive value 95%, and accuracy of 90%. 11% of patients were staged incorrectly, with 7% of patients being overstaged and 4% understaged. In a subgroup analysis with patients with nodular Barrett's esophagus, comparable sensitivity and specificity were achieved, although 15.5% of patients were staged incorrectly. In a multivariate analysis, we found that nodular Barrett's esophagus and advanced T staging requiring surgery were independently associated with incorrect EUS staging, with an odds ratio of 0.35 and 0.12 respectively. In other words, nodular Barrett's esophagus had a 65% lower chance of correct EUS staging than patients without a nodular Barrett's esophagus. And patients with advanced T staging requiring surgery had an 88% lower chance of correct EUS staging. In summary, we found that esophageal EUS has a limited accuracy selecting patients correctly for endoscopic treatment or surgery, with overall 11% of patients being staged incorrectly. These findings are consistent with recently published smaller retrospective studies from Europe and the US, including 131 and 135 patients respectively, which found that EOS had no impact on the decision-making process, nor did it alter management using biopsy or EMR specimen as standard criterion. Our study has several limitations, including its retrospective character and the debatable cutoff for patients to undergo surgical resection, which we set at an adenocarcinoma invasion depth of T1b or deeper, or the presence of N1. This is important, as recent studies showed that patients with T1b SM1 invasion depth might benefit also from endoscopic treatment. Further, this is a cohort study of a tertiary gastroenterologic referral center. The percentage of non-dysplastic Barrett's esophagus and Barrett's with low-grade dysplasia is slightly higher in practice settings without a referred patient population. When we interpret the results, we need also to account for the fact that patients in whom the EMR identifies T1b cancer or other indications for surgery would undergo a preoperative staging EOS. This applied approximately to 8% of our patients, in other words, 1 in 12 patients. This could argue to perform an EOS at the time of EMR to avoid another endoscopy on a separate occasion. In conclusion, this study shows that EOS has a limited role of staging Barrett's esophagus with suspected high-grade dysplasia or cancer, which is consistent with the recent ACG guidelines. Thank you very much.